He will be talking on no more tunicates in knee replacement. Dr. Sandeep, please.
So, good evening, everybody, and thank you for this kind invite to the AMC. I would like to thank the organizing committee and I'd like to congratulate them for organizing such an excellent function. So, my topic is the most rudimentary topic of the all talks which we are going to have today. We have talked about robotic surgery, we have talked about valgus knees, varus knees, asternal fractures. I'm going to talk about something very rudimentary, which is a tourniquet, which all of us have seen, used, and maybe use every day. Now, the discussion we are going to have on is tourniquet actually necessary in a knee replacement? And if it is not, can we let it go? So, let's talk about the prevalence of what is the prevalence of tourniquet use. So honestly, because the Indian data does not have any regularity, we just depend on the Western literature to understand what is the relevance of youth. So what we see that the prevalence is around 90% in all the foreign registries, in the Swedish, the UK, and the US registries, the incidence is about 90%. And I am sure in India, it should be mirroring something like that only. Now the question is, where's the evidence that supports that kind of use? Now, in my question is that in total knee arthroplasty, this is a practice which has been completely unchallenged with a focus on the benefits, but absolutely no or little on the potential harms. The evidence which comes from data shows that there are substantial risks and no major advantages to patient and which question the routine use of tourniquet in a total knee replacement. Now, there are some myths and some facts which are associated with tourniquet use. Myth number one, the view is better when we use a tourniquet. Yeah, possibly. Using a tourniquet improves the surgical field of view. But if we have a friendly chat with our anesthetist and they're happy to provide hypotensive anesthesia and we as surgeons do minimal hemostasis, the view can be exactly the same like using a tourniquet without the side effects. Myth number two, compromise cementing. Now, this is something a lot of my colleagues are worried about when they're not using a tourniquet. As we all know, most of us in India are still using cemented I will be very surprised if somebody is using cementless implants in this room right now. So, because we are using cemented implants, so our concern is that these cement implants should interdigitate well with the bone, and that is the whole longevity principle here. So most surgeons will believe that if we use a tourniquet, it reduces bleeding, and therefore the porous bone ends are free, and that is why the cement digestion can happen better, and that is why implant longevity is better. This is a great myth which has been shown by multiple RCTs and multiple studies. So what these RCTs did is that they checked implant stability, and I found 7 RCTs on that, and these 7 RCTs included 529 knees, and one study was actually long-term stability. So what they measured was tibial cement presentation, radiolucent lines, percentage of radiolucency at the tibial bone interface, and translation of tibia and the recurrence rate. So what they found is that using a tourniquet for primary cemented TKR does not reduce a risk of revision. So the rates of revision are essentially same for using a tourniquet or not using a tourniquet. So that argument that the cement interdigitation will not place is absolutely wrong. Myth number 3 is blood loss. Now, using a tourniquet, although it gives you that feeling that at the time of surgery there is lesser blood loss, but in eventuality, the total blood loss is maybe more for the patient when we are not using a tourniquet, when you are using a tourniquet versus not using a tourniquet. How? There's something called hidden blood loss. So although there is less intraoperative blood loss after the surgery, because we have not done hemostasis as good as during the surgery, well, if we do not use a tourniquet, there is greater perioperative and postoperative loss. So in my practice, what we make sure that we use hypotensive anesthesia, intravascular tenofovir acid, and meticulous hemostasis. That is our standards. We do not use tourniquet in more than 90% of our cases. Only in some cases which have uncontrolled hypertension, we might use a tourniquet. Now, coming to the facts to tourniquet use? The number one fact, which is undeniable, and most of will have to agree with that, is pain. A tourniquet causes pain. The tourniquet causes pain because it damages blood vessels and the local soft tissue activity because of it increases the fibrinolytic activity. So if you, just in your practice, just try not using a tourniquet for a case. So when you see a case which you have not used a tourniquet and compare with this with another case who have used a tourniquet, the person without a tourniquet will absolutely have lesser pain But this is for the first 1 week to 10 days. After that, both the pieces will be same. But for the first 1 week, 10 days, 15 days, the people who have not been used a tourniquet will definitely complain of lesser pain. Fact two is now we're getting into serious stuff, DVT and systemic emboli. Now, whenever we are using a tourniquet, we are putting that patient at threat for a higher risk of DVT than not using a tourniquet. We have had systematic reviews which have shown that tourniquet may increase the risk of VTE. So whenever you have a patient who is already high risk, please don't use a tourniquet. Systemic emboli can go into the bloodstream and can potentially cause cognitive impairment and maybe at very low level stroke also. What happens is as soon as we deflate the tourniquet, there's a shower of clots which go inside the vessels. Now, some of these clots can go from the pulmonary capillaries to the veins, and that can actually go into the circle of Willis, can cause strokes. Now, there has been a very interesting study that shows that whenever there's a tourniquet being used, the cognitive decline in patients is more than people who have not had used tourniquet. Fact three is again, which I'm sure all surgeons will be very worried about, is wound complications. Superficial wound, I'm not talking about deep infections or deep complications, I'm talking about superficial wound complications. So studies have shown that tourniquet use causes increased complications like infection, blister, hematoma, wound oozing, bruising, nerve palsy, and reoperation. So superficial wound infections are directly proportionate to length of a tourniquet time. I am very scared when my tourniquet time is more than 1 hour in any case. So we make it as think that if you're thinking of a long case, do not use a tourniquet because the rates of infection will absolutely increase if you keep using a tourniquet for 2 hours. I am sometimes amazed at people who use a tourniquet for 2 years. They are much more stronger than I am, in will at least. Number 4, length of stay. Now, length of stay has been shown by 12 to 15 studies that there are people who are not using a tourniquet will have their patients go home earlier. Now, when we are talking about robotic surgery and LOS and all those things, where robotic surgery we just have early results of robotic surgery that the LOS is shorter. But tourniquet, we have long-term studies, so we should actually be thinking about this. Fact 5 is altered tracking. Whenever there's a tourniquet on, the tourniquet can potentially cause the lateral retinoculum to be tight, and that can give you a false thing of that the tracking is not, and lead you to do releases which you actually don't need. So if we are using a tourniquet, especially for beginners, if you're using a tourniquet and the tracking is not right, just deflate the tourniquet and check again. You might just be right. So before releasing, always check that, because it is just because of increased lateral reticular tension. There are some things where places where a tourniquet is a complete no-no. Now, this can be completely seen in just an X-ray. When I was doing my fellowship, I had this one case I had to do in the morning, and my boss told, don't do it. I was like, what happened? He's like, no, you can see calcification, don't do it. Please don't do this case. I was like, okay. I was a bit upset, but now when I have 10 years into my practice, I know why. Because all these patients who have a low ABPI, have pulses which are not good, have calcification, have intimal calcification, you have to be so worried because you have to tell the family about it. You have to tell the family there's a potential of a neurovascular compromise, because whenever that happens, you cannot go back. And then it's a big story which you don't want to encounter. So calcification, especially intimal calcification, which you can see on the X-ray, is a very big no-no sign, and you have to properly counsel and make sure that you do all the Dopplers, you do a CT angio if needed, and make sure that you can do all preventive steps before doing the surgery. I'm just going to wrap up in a minute. Optimal pressure, again, very debatable, but in my practice, less than 250 whenever we use it. So the take-home message here is the results demonstrate that tourniquet leads to higher risk. There is no evidence to suggest any major advantage. So through this talk, I am hopeful that I'll be able to convert at least a couple. So I had a chapter on this same thing in about 2 to 3 years back in a book called Infection Knee Replacement, where we just focused on, so you can go there for further reading if anybody likes, or I'll be happy to help you in that. Before I end, I just want to end with a request to all my lovely colleagues in Bihar that we are having this online voting system for the Indian Orthopedic Association conference. Odisha is pledging very strongly for IOCON 2025, and I ask all my colleagues and request them to please support us in that cause. Thank you very much, and thank you, Ashish sir, for your kind invitation. Thank you. Bye. Any questions if I'll be here?